Hello, everybody. My name is Jeremy Birkmeyer. I'm very happy to be welcoming you guys today to our very first debate. I'm the president and founder of an organization called ARGU-EBM, or Averting Groupthink Union for Evidence-Based Medicine, and I will be tonight's moderator. ARGU-EBM is a new medical student organization at Baylor College of Medicine that facilitates scholarly discussions or debates on challenging or controversial topics in medicine through the rigorous, technical, and critical appraisal of evidence. Though I will be our moderator tonight, I'd also like to thank our Vice President Reagan, Technology Chair Clifford, Public Relations Chair Gabby, and our social media team, Malay, Will, and Chris, for their efforts in making tonight possible. Tonight marks our debut and very first debate, so we kindly ask for your patience should we encounter any hiccups. And we hope to have a debate or discussion like this once every month. So if our mission resonates with you, please be sure to follow us on our various social media platforms to stay up to date and visit our website to learn more and participate. This debate is being recorded to be posted on YouTube. I'd like to note a quick disclaimer. Baylor College of Medicine and ARGU-EBM do not and will not endorse any of the specific speakers or their viewpoints, and the information presented is not medical advice. Joining us tonight are Dr. Stephanie Sherman and Dr. Zaven Sargsyan to debate the topic, do we currently overtreat infectious fever with antipyretics given the balance of adverse and beneficial effects of fever? Allow me to introduce you all to our two speakers. They've told me to use their first names from here on out. So, Stephanie graduated from medical school at the University of Michigan and completed her internal medicine residency at Massachusetts General Hospital. She loves working with patients and learners as hospital medicine faculty at Ben Taub and the VA. She also serves as an associate program director for internal medicine residency and editor for images in clinical medicine for the New England Journal of Medicine. Tonight, Stephanie will be defending the current practices surrounding antipyretics and infectious fever. Stephanie, thank you for being here. How are you this evening?
Doing great. Excited to be here on this inaugural event and honored you guys are going to spend a little bit of your Monday evening with us.
Yeah, thank you so much for being here. So we'll now introduce Zaven. Zaven graduated from Baylor College of Medicine in 2011. He did his residency in internal medicine at Massachusetts General Hospital before returning to BCM in 2014 as an academic hospitalist. He rounds at Ben Taub and the VA and participates in many aspects of medical student and resident education. His favorite diagnoses include AV-NRT, severe B12 deficiency, and murine typhus. Tonight, Zaven will be arguing for more conservative antipyretic practices and infectious fever. Zaven, thank you for being here. How are you this evening?
I'm doing great. Thanks for this, Jeremy.
Yeah, awesome. Thank you guys for being here. For everyone watching live, we are now going to post a poll. Please submit which position you most align with currently, and then we will revisit this poll towards the end. For Baylor students participating in the Service Learning Program, you can earn 1.5 SLP points if you stick around for the QR code at the very end. This debate will last a maximum of 65 minutes, composed of opening statements from each speaker, the rebuttals, a period of crossfire discussion, closing statements, and then 20 minutes maximum of audience Q&A. After this time, we will take a closing poll to gauge where opinions have shifted. For each segment, if speakers mutually feel like there is nothing else to add before their time has expired, they can cede the remaining time and we'll move on. Lastly, it's important for me to note that although debate has become an emotionally charged word, disagreements can be had without being disagreeable. We ask our speakers and everyone viewing to approach this conversation first and foremost with humility, recognizing that we as medical professionals and scientists hold the pursuit of truth as the foundational ethic that unites us all. Zaven and Stephanie, anything you'd like to quickly share before we begin with Stephanie's opening statement?
Thanks, Jeremy. I'll just say I love seeing the spread already that's out there. Well, I'm excited to see how that shifts. And then I want to add, I don't know if it's quite a disclaimer, but one additional biographical context for us as speakers tonight, including a little history. You might have noticed Zaven and I did our residency in the same place. That's where we met. We became kind of good, nerdy friends in internal medicine, and then more than friends, and we are married. So I think it's important for people to know that we know each other well. We talk about this kind of stuff all the time, and it's very exciting to have a more formal venue, maybe to chat about some of this stuff together. I'll also add, we as senior residents had to do a talk, like an academic conference of anything that interested us in front of our program. And we actually paired up with a couple other co-residents and did our senior resident talk in residency on fever. So this is kind of a great callback for us.
Nice.
From kind of earlier in our careers, a topic that's super relevant super interesting, has got a lot of written about it. So excited to talk more about it with Zaven years and years later.
Cool. Thank you for that context. Yeah, that's news to me. I did not know. They just told me a little while ago. So awesome. Anything else to add? If not, we will start with Stephanie. Okay. So, Stephanie, please share your screen and begin your opening statement. You will have 10 minutes with a 1-minute warning starting whenever you begin sharing your screen.
Sounds great.
All right.
All right. I come to you guys this evening with this simple message: keep treating fever. And I don't think I'm alone. Already, many of you on the poll said that you understand that there's benefit for giving antipyretics when someone has a fever, particularly in the case of infection. And this isn't news to us as human beings, as physicians. And what discussion about a medical topic would be complete without kicking off with a quote from William Osler, who said, "Humanity has but 3 great enemies: fever, famine, and war. Of these, by far the greatest, by far the most terrible, is fever." There's sort of 2 main tenets that I'd like to defend the position of treating fever with in my opening argument. And the first is really the importance of mitigating the potentially deleterious effects that happen with pathophysiology when someone has a fever. So by way of definition, a fever is defined as a change in the set point of the hypothalamus that's due to usually an intrinsic stimulus. The body has a lot of responses in relation to that. Vasoconstriction happens peripherally in order to preserve heat. Metabolic demand goes up. There are thermogenic processes in the body, both shivering as well as kind of brown fat functioning in a non-shivering manner. So the body heats up, hits its set point like a thermostat in your house. And once it's at that set point, right, to not overshoot it, there's mechanisms for cooling. And so you're very, very metabolically active with the state of meeting your new set point and then making sure that you're not too fast beyond it. You vasoconstrict and then you vasodilate and your heart gets fast and then it slows down. There's just a lot of stress on the body, which in a lot of individuals is a lot of demand for their body to meet. Specifically, the cardiovascular demand in some patients that are created by the tachycardia of increased metabolic rate, the vasodilation that can lead to hypotension that happens once the set point is there, can be extremely problematic, particularly for critically ill patients. The metabolic demand going up, and it goes up about kind of 13% per degree of fever in Fahrenheit, results in more carbon dioxide production. To get rid of that CO2, what do? You increase your respiratory rate, which again can be a problem for any patients who've got underlying pulmonary conditions. And then finally, that higher thermal set point can cause problematic issues in the brain. It can lead people who are predisposed to being delirious with fever, can actually stimulate and make brain injury that's present worse. We'll sort of get into that a bit later. So really a very kind of appropriately sort of activated set of physiology, but a physiology that can be really problematic for a lot of our patients, particularly older patients, patients with a lot of comorbidities, and thus blunting this effect is really important for maintaining the stability and hemodynamics of patients, particularly who are sick. To unpack particularly the cardiovascular effects a little bit more, I want to show you guys one image from this study published in a critical care journal over 10 years ago. That was a randomized controlled trial of what impact fever control had using external cooling devices, so not just Tylenol and ibuprofen, on how someone shock did. And what they did, you'll see that x-axis down here is hours of the study. And the y-axis is the percent of patients who could drop their vasopressor requirement, right? These pressors that were needed to actually maintain their blood pressure in the face of hemodynamic shock. And they compared those who were cooled in the dark dots to those who were not cooled down to a more normal temperature in the open dots. And what they saw very quickly in the span of half a day, 12 hours, that those who were cooled during this extreme metabolic stress of septic shock were much, much more dramatically able to drop their vasopressor requirement and again, be able to sort of balance their physiology and get back to normal sooner. So just one snapshot of showing the effects both of having fever and cooling from it and the potential benefit to actually bringing fever down in what hemodynamic baselines and support can be. I mentioned also fever has effects cognitively, and I really brought up the case of people who are prone to delirium, but I actually want to show you guys an oldie, but hopefully a goodie from 50 years ago. And you can see it's 50 years ago when you see the study design that showed that perhaps even healthy young people do better cognitively when they have a fever and they're given antipyretics. So I know it's mostly students on there. Think about this. If you're about to take a shelf and you've got a mild fever coming, I'm going to see if I can convince you to take ibuprofen or acetaminophen before you take your shelf. What they did in this study, again, 1974, don't think we could reproduce it these days, is they took 20 volunteers and they inoculated them with something called a sandfly virus. It is a self-limited virus that gives people a fever, makes them feel a little crummy, and then it goes away. And then they compared them to controls. And of the 20 that were inoculated, half were given antipyretics, half were not. And they had controls after who were given nothing and were also given antipyretics. And before they started the study, they had all of these young, healthy people, by the way, who were 18 to 20 years old, no comorbidities, practice a cognitive task and set a baseline of how good are they basically at this like memory test. They then gave the virus to some of these individuals and they saw how did they do on that test they had practiced as their fever went up. And what I'll highlight for you in this graph is this dashed line curve. This represents those inoculated with sandfly fever, whose fevers were allowed to go up as high to 39 degrees and then come back down on their own over a period of days. That's what the x-axis is. And you'll see a correlation. These young, healthy people with no dementia, no prior strokes or anything performed 20% less well when they were febrile compared to when they were afebrile. So again, another signal that fever itself has negative impacts even in young, healthy individuals. We talked about the cardiovascular realm, but not only that, also the neurocognitive realm. My kind of second and final opening argument is really going to be on the purpose of treating discomfort and suffering when you have a fever. I mentioned some of the physiologic effects that happen, tachycardia, tachypnea, profuse sweating. It doesn't feel good. You guys know this from personal experience. You know it from pop culture. And Zaven and I are parents of young kids. The pop culture we're exposed to these days is Bluey. And Bluey even has an episode talking about fever with the mom saying she's not feeling the best, kiddo. She's got a bit of a fever. And I know this is a talk about EBM. We're really supposed to be basing our arguments in published evidence, but anecdotes and empirical experience, I think, mean a lot. And I will ask Zaven, my counter argument partner here, what happens to his own son, his youngest son, when he gets a fever? So this is our now 4-year-old Ruben, who was 2 at the time of this image. Had a febrile illness, probably staph-related with skin peeling. He was miserable, not feeling well, crying, but couldn't actually take anything down. He felt so unwell that he was vomiting, and we were very worried about this vicious cycle of dehydration, fever, getting worse. So why wouldn't you treat a fever in a guy like this? Zaven? We did, in fact, in this case. So I'll just cite our personal experience, although I know, again, we're focusing on the evidence. If you want evidence about how antipyretics actually work to make people feel better, this was a randomized controlled trial that really looked at different doses of both aspirin and acetaminophen and how much better it made people feel within the hours after they took the dose.
1
And
minute
they looked
warning.
at a lot of different symptoms. How much time do I have, Jeremy? 1 minute?
45 seconds. Yeah.
Perfect. Not surprisingly, after these individuals took their dose of aspirin or acetaminophen, whether it was 500 milligrams or 1,000 milligrams on a scale of 10, with 10 being the worst, over the period of hours afterwards, the specific symptoms of feverish and feeling badly from that went down accordingly. So antipyretics work, they make people feel better. So I'll conclude there. Treating fever, we need to mitigate some of that pathophysiology that really makes it a dangerous situation for a lot of our patients. And of course, treat discomfort and suffering, particularly in your own family members. With that, Zaven, I cede the floor to you.
All right. Thank you so much. So Zaven, you can now share your screen and begin your opening statement. You will have 10 minutes with a 1-minute warning starting now.
Thank you, Jeremy. And Steph, I didn't know that tugging at heartstrings was part of the allowable strategies in this exercise. Well done. This is sort of my argument. Okay, I think the premise of the debate, the statement was: do we currently overtreat infectious fever with antipyretics, given the balance of adverse and beneficial effects of fever? And I think that on the balance we do. By the way, Jeremy and everyone, I've noticed in the last 10 minutes that intermittently there's a bit of a lag in the sound. So if I'm sounding laggy, please do let me know, and I can maybe move a little closer to the Wi-Fi booster. But so I believe that lowering temperatures in the setting of infection has potential harms, and that we should be more conservative in the decision of doing so. I will start a very long time ago. When it comes to fever, humans did not start the fire. It has been burning since the world's been turning. The famous words of Billy Joel. Fever arose, it's believed, about 600 million years ago. It evolved sometime after the evolution of innate immunity and before the evolution of adaptive humoral immunity. And it has been preserved evolutionarily with remarkable consistency. Everything on Earth that walks, crawls, flies, gets fever. And evolution is very smart, especially when it comes to such a breadth of species involved and such temporal depth. Evolution generally knows what it's doing. I want to share some fascinating experiments from the 1970s by Matthew Kluger and lizards. Lizards are ectothermic organisms. So they can't regulate their own body temperature internally. It is influenced by their environment. So when they want to get warmer, they move to warmer places. When they want to get cooler, they move to colder places. And generally, they like to hang out at about 35 Celsius. Okay, so a little bit cooler than us. So what Kluger did was to study the effects of infection on thermoregulation and outcomes in lizards. So the first set of experiments was to inject lizards with a known lizard pathogen, Aeromonas hydrophila, and to see how they behaved when placed in a box with a temperature gradient of cold on one end and warm on the other end. And what he found is that lizards tended to move to the warmer end of the box when infected, and tended to increase as a result their body temperature by 2 degrees Celsius. Okay, that's what they did, but does it mean it's good for them? Lizards aren't very smart, right? Okay, so the next set of experiments was to place infected lizards into three different environments, actually. One was sort of neutral, one was a little bit colder than usual, 34 Celsius, and one was warmer than normal, 42 degrees Celsius. And almost all of the lizards placed in the colder environment died. About half or slightly less survived if they were in a neutral environment. And when placed in a warm environment, almost all of them, most of them survived. Now, could that just be the effect of, lizards not liking cold temperatures? Not at all. So when lizards were injected with saline as opposed to bacteria and placed in these three different environments, they all did about the same. Okay, that's just lizards. What other evidence do we have? Infected salmon, also infected with Aeromonas and other infections, tend to swim to warmer temperatures. Bees get fever. So when beehives are infected with certain fungal infections, all of the bees collectively flap their wings more and they generate heat so as to raise the hive temperature in order to fight that infection. And of course, let's move on to who we care about most, which is humans. And there's really good even evidence that fever is bad for a lot of pathogens. So the picture here on the left is a snapshot of something called pyrotherapy, for which I forget his name now. But the Nobel Prize in Medicine and Physiology was awarded. This was how people treated syphilis before there was penicillin. People with syphilis were placed in boxes, and their body temperature elevated to about 40 degrees Celsius. That's quite the fever. And this was effective in treating syphilis. And even after penicillin was available, so-called malaria therapy was still used, where people were injected with malaria, given malaria, in order to become febrile, kill their syphilis, and then given quinine to treat the malaria on the back end. How does this work? So there's direct anti-pathogen effects of fever, but it also boosts your immune response. So it increases the mobility of white blood cells. It increases phagocytic activity of neutrophils and macrophages. It increases proliferation and action of lymphocytes. And there's a lot of studies I'll go through quickly, sort of showing more in practice how this works. And all of these will be randomized trials. One is actually, sorry, this one isn't a randomized trial. This is a retrospective analysis of patients with sepsis, showing that fever is associated with improved outcomes, whereas hypothermia is associated with worse outcomes. And the outcome we're talking about is mortality, and the differences you see at the bottom of the screen are stark. So these are patients with sepsis. Those who had fever survived at a rate that was twice as, or the mortality was twice as low as people who were hypothermic. The rest of the way, there's a couple of interesting and older randomized trials. In this one, similar to Steph's quoted experiment, people were given a virus. They were sort of caused to have rhinovirus and then randomized to receive either aspirin in this case or placebo. And this study showed that viral shedding was increased in people who received the antipyretic. Another study of 60 healthy volunteers also administered intranasal rhinovirus, and they developed a rhinovirus infection and randomized to receive either aspirin, acetaminophen, ibuprofen, or placebo. And this study showed that those who received the antipyretic had decreased circulating antibody levels and counterintuitively, perhaps, actually had an increased duration of symptoms. And another study of the effect of antipyretic therapy on outcomes in critically ill patients, a randomized prospective trial. This was a randomized trial of 82 patients in a trauma surgical ICU who had been there for more than 72 hours and survived so far. And it excluded patients with traumatic brain injury, perhaps to Steph's point of the brain being particularly sensitive to hyperthermia. And the randomization was to treat fever with antipyretics at a threshold of more than 38.5 Celsius, so about 101 degrees, or to not treat until you were really febrile, 40 degrees Celsius, and that was the permissive group. And what they found is that there was a higher incidence of infections in the aggressive antipyretic group. And the trial was actually stopped early at the interim analysis because there were 7 deaths in the more aggressive group as compared with only 1 death in the permissive group. The last study I'll share at this point is just another kind of setting, another organism, another population. These were 50 children in Gabon, and all of whom who had Plasmodium falciparum malaria. And they too were randomized to receive mechanical antipyresis above a certain threshold, and then the use of acetaminophen versus placebo to reduce fevers. And this study found that the clearance of parasitemia, the ability of the actual malaria to be cleared from your blood, was delayed in the group that received acetaminophen by a mean of 16 hours.
1 minute left.
Thank you, Jeremy. So I'll end with one more study. This was a systematic review and meta-analysis of a whole bunch of patients, a whole bunch of studies in slightly different settings, but all in patients with sepsis. 8 of them were observational, 8 randomized, and studied the effect of antipyretics in outcomes, specifically mortality, and showed that there was no benefit in lowering and treating fever, neither in hospital nor 28-day mortality. And when a sub-analysis of only the randomized trials were done, this was a smaller group of patients, but still quite a few, 1,500, the outcome was the same. There was no improved mortality when you lower temperatures. And this was preserved whether you were using acetaminophen or NSAIDs versus acetaminophen versus mechanical cooling. I'll stop there, but I hope to have shown you guys that there's some reasons to think and some evidence that lowering temperatures in the setting of infections can be harmful.
Awesome. Thank you. So we're now going to move into the rebuttal phase. So Stephanie and Zaven, you will now have 7 minutes each to present rebuttals or focused elaborations to the arguments posed in the previous segment. Sorry, Stephanie, you have 7 minutes with a 1-minute warning starting now.
Thanks, Jeremy. The more I learn about bees, the more respect I have for them as a species. They are just really cool. And honestly, a lot of those animal studies are just fascinating, and knowing the process throughout living beings of how fever has been part of our physiology. You know, I will say some of those animal studies, in vitro studies, historical studies from pre-antibiotic era are a little bit apples to oranges to where we are today in 2025 in medicine. And I think the bottom line is there's few really high quality kind of prospective studies in humans on this. And the human creatures are just more complex, but also have access to antibiotics and other medical care that the lizards and the bees that they may encounter don't have. So I think it's an interesting basis for it, but I think makes it a little hard to translate into our actual clinical practice. You showed us some studies that hinted that there could be lower mortality in those who had higher temperatures. My kind of thoughts on that are first, fever, which we mentioned, right, as a response to the hypothalamus kind of being reset, is we didn't talk about what it's generated by. It's generated by pyrogens, by inflammatory cytokines, right? Just this huge activation of the immune system. And fever is a symptom of that immune activation. But I don't know that lowering the temperature means that you're immunosuppressing someone, right? You're lowering a symptom that comes with it while still letting the immune activation potentially do its job. I think one thing, when you really look at the fine print of some of the studies on the benefit of fever, particularly in critically care patients, in a lot of the meta-analyses and systematic reviews, there's not necessarily a standardized method of temperature assessment in patients. I think that's just important to recognize, because more invasive temperature measurements, things like rectal thermometers, pulmonary artery catheters, they result in higher values. So you have to be very careful looking at some of these studies that they acknowledge when they're pooling all of these studies together, the method of temperature measurement, because more critically ill patients that are being more invasively monitored, right, might actually have temperature readings that are different from those who are less ill. So just something to be careful about when you look at the study population. And I think with all of that said, the fact that in some of these studies mortality was lower at the higher temperature doesn't mean the opposite. It doesn't mean we're going to increase mortality by making the temperature lower. I think I've iterated these points. This was a particular systematic review done published in BMJ in 2022 that, again, looked at fever treatment and made the conclusion these studies don't show us any mortality or benefit in serious adverse event prevention. But again, the methodology of the study was very heterogeneous. How they intervened on the fever, what the actual cause of the fever was varied. And again, a lot of these studies don't have the patient-centered endpoint of how did it affect their experience of their illness? Did they feel less crummy if their fever was treated or not? which, I think feeling crummy but staying alive, right? We would all choose that, but I don't want to undersell sort of the quality of life benefit that I think may be there. And then I briefly want to come back to kind of fever and brain injury and just tell the brief story of how our knowledge and how treating fever via targeted temperature management with an external cooling machine like this in patients who've had a cardiac arrest, who have poor neurologic status afterwards, treating fever actually improves their neurologic outcomes. And the story is, if we go back about 20 years, the first randomized controlled trial actually compared cooling people with a bad neurologic status after cardiac arrest to 32 to 34 degrees compared to letting them just do what their body wanted. And with cooling, those people actually did a lot better in terms of waking up and having better brain outcomes. So the thought was at first, and this was true when Zaven and I were residency, that the hypothermia was in fact therapeutic. But another study was done more recently, published in the New England Journal of Medicine, that looked at cooling down to hypothermic temps compared to just not letting people get febrile. And they found that just keeping people normal thermic, again, with these external cooling machines, in other words, treating their fever, was as good as hypothermia in giving people a better prognosis for their neurologic outcomes. So the post ROSC guidelines after cardiac arrest, when someone's had return of spontaneous circulation, and ACLS, as well as the American Heart Association algorithms, make treating fever and making people normal thermic after cardiac arrest one of their key guidelines based on this evidence. And the story really is here. We thought it was cooling, but in fact, it was mitigating fever was the positive effect in these critically ill patients. I'll make one final comment here, and that is there's potential downsides to ongoing fever when it comes to our decisions. 1 minute for me, Jeremy?
Yep.
Perfect. And that is, if we don't treat fever, does that affect our decision making as physicians? And if any of you have been to the doctors with fever for a week or taken care of someone in the hospital who has ongoing fever, it influences us to give more antibiotics. And that's usually because we're worried. We don't want to miss a bacterial infection, although bacterial infection might not even be there. And this was an interesting study from England that showed that in a cohort of a total of 8,000 patients, the longer the fever was on, the more likely physicians were to actually start giving that person antibiotics. So fever itself, I think, is something that affects our therapeutic decision-making, could potentially lead to over-antibiotic use or over-antibiotic broadening. So just a therapeutic consideration to have there. And NSAIDs and Tylenol are really, really safe in short doses. The studies that have shown even in healthy people that they can elevate liver function tests, for example, that's with 10 days of use. So spot dosing these medications to make someone feel better, again, in most patients is very, very safe and could be helpful. Thank you.
Time is up. Awesome. Great. Okay, so Zaven, now it is your turn for your rebuttal. You will have 7 minutes with a 1 minute warning, starting whenever you share your screen. Awesome.
Thanks, Jeremy. Steph, I have to push back. I made this slide while listening to you against one thing, okay? Most medical students, I think these days, believe it or not, don't know who Osler is. So William Osler is considered like the founding person of internal medicine. He was an internist at Hopkins. He invented rounding, okay? And you guys might know how much internists love to round, okay? And he has a lot of amazing quotes and contributed a lot to the field. But in that quote, come on, he wasn't referring to an elevated body temperature. Fever back then in the old-timey days meant infection. So he wasn't necessarily in your camp on this one. Anyway, I want to reiterate that all of the creatures and humans and that developed the ability to have fever and maintained that ability to have fever for their entire existence had brains and hearts and coronary arteries and the ability to feel achy and uncomfortable and throw up and all that stuff, and yet it persisted. most of y'all haven't seen this in the flesh yet, in the live audience at least, but um, if I were to propose to an intern, a resident, a practicing physician that an order set by default in the hospital should have the order for metoprolol, which is a beta blocker and slows down the heart, every 6 hours administered every time the heart rate, goes above 90 or 100. Or if I were to suggest that opioids should be given as soon as the respiratory rate crosses above a certain threshold to prevent that potentially uncomfortable, potentially physiologically taxing abnormality in the vital sign, nobody would like that. And yet we accept, and it is part of most admission order sets, what most physicians do these days, to order acetaminophen PRN temperature above 98 Celsius, 100.4 degrees. And that's the practice that I think is too much and overdone and not based in sound understanding of real benefits and risks. There's just not the benefit. I will be brief in my rebuttal and stop there to prioritize some good back and forth with my co-debater in the next phase.
Okay, awesome. So we will now move into the Crossfire section, which will be 20 minutes, where Stephanie and Zaven will freely ask each other questions and exchange arguments. Zaven, what would you like to ask Stephanie to begin the discussion?
How's it going, Steph?
It's good. All good.
I guess let me ask you this, Steph. I know we're on sort of opposite sides of the equation. But if you got called by a nurse on a hospitalized patient you're treating with pneumonia with antibiotics, and the nurse called you and said, "Hey, patient just spiked the fever to 98 to 9, 100.1, 100.9, whatever, and I don't see a PRN acetaminophen order. What would you like me to do? What would you do, and why?"
I will, as we get into more discussion, maybe soften my dogmatic approach a little bit and say that, as with many things in medicine, context is important. So I would want more information about what's going on. If this patient admitted with pneumonia now with a fever 100.9 was tachycardic at the time, whether sinus tachycardia or certainly in an atrial tachyarrhythmia like atrial fibrillation, if he were feeling sweaty and uncomfortable or achy, I would not hesitate to giving him antibiotics. Sorry, giving him antipyretics because he's having a fever, but he's on antibiotics. And yeah, he's feeling uncomfortable with it. I'm just not worried in that patient that treating that fever is going to suddenly send him down the tubes and, lead to him being in the ICU. That's just the reality of it. I will say if he is totally asymptomatic, the nurse was just being very thorough, letting me know an abnormal vital sign. But if the heart rate, the blood pressure, the patient's symptomatology are completely normal and stable, truthfully, what you mentioned about having just rote administration of medications at certain thresholds is truthfully something that I wouldn't do in real life. I'll make one quick comment because I know we've got a lot of students on who are early in their clinical training. I, even in real life, am fairly flexible about thinking about what is a fever. you all may have heard before that older adults have lower baseline temperatures, and that's true for every decade. It's not a huge difference, but for every decade of age, the temperature goes down kind of a tenth of a point or so. Not huge, but someone who's 90 is going to have a temperature that's close to a degree lower than someone who's younger. And how you manage a 99.9 in that person compared to how you would manage a 99.9 in someone who's young and healthy. I would just say, I think being categorical about what is a fever is its own sort of problem in this issue. If I had a 90-year-old patient who was 99.9 and feeling hot and feverish and uncomfortable and achy and was in atrial fibrillation with a rate of 120 beats per minute, I would give that person Tylenol for a 99.9. So that's sort of my answer to your question, and just adding some nuance on the real life that in a lot of these studies and how we learn about fever, we learn about it as a dichotomous variable when in fact it's continuous, right? And is the 99.9 that maybe that's a fever for him, or maybe he's on his way up or he's on his way down, and thinking about all the data points and context, I think, is a real life approach to it. Thoughts, reflections on that?
I think, yeah, something you said made me like when you said I wouldn't hesitate to give that person some Tylenol because I don't think it would harm them. And I have to concede that the study that I cited showing no benefit fever in humans, and like those like 8 randomized trials that were meta-analyzed, nor was there a signal for harm, right? So I think I have to I think that's a good point that I too, like if there's an actual problem that we're witnessing beyond just the number in an individual patient, I probably wouldn't hesitate too much to lower that temperature too in those particular cases. Let me ask you another question, Steph. You brought in our kids into this, so I'm gonna keep using them to reflect and so one of our kids, the older one, he gets a fever and he's a little whiny and stuff, but he's generally less bothered by it. Our younger kid, when he's febrile, he vomits. That's his manifestation. And I think probably the only times he's ever vomited has been when he's febrile, and probably at least half the times that he gets a high fever, he ends up vomiting. And then the trouble is he's not holding on to fluids, he's not eating, he might get dehydrated. And now we can't give him Tylenol anymore because he's vomiting. Like you'll just spit it back up. And when we're smaller, we sometimes did suppositories, but it becomes harder as they get more feisty, right? So Steph, would you treat fever differently? I guess it's a similar question, maybe have the same answer. Like, should we be more inclined to treat Ruben's fevers because he experiences them differently and has kind of complications thereof, as opposed to Simon? And then could we apply that similarly to our patients as well?
Yeah, and I'll just say for the group, right? We do internal medicine, we take care of adult patients, and as a parent having a febrile, vomiting, unwell kid for the first time when that's not your medical specialty, it's just, right, it's very distressing. And I think, yeah, when we first encountered this as parents, we were both more comfortable with the 90-year-old with rapid atrial fibrillation and diaphoresis and sweating than the 1-year-old with vomiting and crying. So just to let you know kind of where our comfort zone was versus wasn't. I think my answer to does an individual's physiologic response and symptomatology to fever change if I would treat it? I think it would change the threshold at which I treat it, but I still wouldn't let a person or a child who gets less unwell, I don't know, there's a certain number at which I would worry about them happening it. So I think maybe my answer would be like threshold for treating is lower in the kid with more symptomatology and more severe symptoms. But still, even the discomfort being less severe or potentially negative in another child. I don't think we should not treat for that reason, but maybe just think about what the thresholds are for it. I don't know. What do you think?
I don't know. To me, I'm still compelled by the data I presented and that exists to that again, fever is there for a reason. It helps to fight infections, and lowering it as a reflex most of the time as a default. Are we just actually extending the illness? There's actually a set of data that I didn't share because it was a little bit outside of the scope of the prompt, right? But that actually antipyretics in a setting of vaccines, sort of to prevent or treat post-immunization fever, actually lower the effectiveness of the immunization. This is pretty well demonstrated that your antibody titers, your subsequent sort of the efficacy of the vaccine is reduced. If you say, here's your shot, and then your kid might get a little fussy, so like give them some Tylenol tonight so that they sleep better. Um, and again, like I think there's something there. Like the fever is part of the immunogenicity, the immune response, fighting the infection. And unless there's a very strong reason or compelling reason, why mess with that?
Yeah, I think that's a fair point. Do I have time, Jeremy, to fire a question back?
Yeah, you still got like 10 minutes, both of you.
A question about how fever makes doctors think for you, Zaven. And that is, some of the literature and discussion on this topic makes the point against treating fever that fever is a vital sign. It's a vital sign. It's a sign that's very helpful and useful for us. And some of the discussion is whether treating fever takes away an indicator of prognosis. How are they doing? Are they getting better or not? Or, are we even treating the right infection or not with these antibiotics? So I'm curious kind of what your thoughts are on one reason against treating fever is like covering up a piece of diagnostic data that may be helpful.
Yeah, I'm all about that. Thanks for asking that. And I've actually sort of argued for that, the importance of that in a setting of a different vital sign, which is the saturation of oxygen, and how one of the downsides of sort of overusing supplemental oxygen is essentially taking away one of the only 5 vital signs we have diagnostically, right, to sort of see what's going on. And I found it, so yeah, I think there's a diagnostic value there. But it's so interesting that you kind of made an argument of, cover up the fever so that doctors don't get anxious, don't get antsy about it and give more antibiotics when they're not truly indicated, right? So, and I would hate to make that argument personally. I think we should sort of aim to be smarter than that, right? Like I think let's preserve our vital signs and the diagnostic value therein, and interpret them appropriately, because there will be situations where we think we know what we're doing, we think we know what we're treating, but the treatment isn't working. The infection is winning, or there's a complication or an abscess or an empyema or whatever, and we need to know if someone's still having an inflammatory response. So I would err on the side of like, let's preserve the diagnostic value of that by not overtreating fever, and then be better at knowing what a normal kind of time course of convalescence should be, and resist the temptation, the urge to whatever, like do more, to give extra treatments when it's not time yet to worry that the infection may not be under control. Steph, I'm compelled by the therapeutic hypothermia slash, what did you call it? The
Therapeutic
maintenance of normal temperature.
normothermia.
Yeah, therapeutic normothermia in the setting of post-cardiac arrest, because the truth is, yeah, like yours and my patients are older with very vulnerable brains, and yeah, like I guess that the hard evidence, and if I remember correctly, the number needed to treat in those studies was pretty low to affect a better neurologic outcomes by not allowing fever, essentially, right? And I don't know how to square that with with everything else. I guess that's where sort of there is a potential balance of benefits and risks that I too must acknowledge. Jeremy, can I ask you a question?
Sure. Yeah.
I wonder if I don't know if, like, to preserve the format, we can move on to the next stage, and if there's a few extra minutes left over at the end, maybe we can take some questions from the live audience instead. But I don't have too many more questions for Steph. I don't know if how you feel, Steph, but
Yeah, we can totally move on. Want to? Okay, sure. So awesome. Great job. We will move on to our closing statements.
Jeremy, you accidentally muted yourself.
Oops, you remuted.
Oops, sorry about that. You guys will each have 5 minutes with a 1-minute warning. Zaven, you can start.
Oh, I go first. Okay.
Yes.
It's flipped.
Switch it. That's right.
Okay. To be, I guess that's only fair, right? Because I got to okay. I want to make a point that fever is fire in the figurative sense of the 2024 lingo. All right, fever has been evolutionarily preserved with remarkable consistency despite the metabolic costs, tachycardia, delirium, adverse brain effects, discomforts, febrile seizures, and all other liabilities that we may state and associate with it. And I want to also argue that any and all medical interventions should have the burden of proof to pursue them. Our default should be to do nothing until we have reason to believe that doing anything and doing the specific thing has strong evidence basis for net benefit in a given situation. In fact, there's a long history in medicine of overdoing things, either with no evidence at all or sort of limited evidence, and it becomes sort of a common practice. And then it's very hard to then undo that common practice. Some have called this the phenomenon of medical reversal, of, again, it becoming sort of universal, almost like presumed, right thing to do, and then it taking years and decades, even when compelling definitive evidence comes out to the contrary, for us to stop doing. Sometimes, again, there's evidence of harm. Sometimes it's evidence of just futility and waste of time and resources and money and patients kind of exposing people to risks. So much so that there's this article series in the Journal of Hospital Medicine called "Things We Do for No Reason," and there have been many dozens of these publications reviewing the evidence for things that we do all the time that we really shouldn't be doing. It's low value and potentially harmful stuff. We have physiologic and evidence-based reasons to think that fever is beneficial and that lowering it may impair immune response and thus hurt infectious outcomes. And we should have better proof that lowering infectious fevers is beneficial. And we simply don't. In fact, one of the things we do for no reason articles is titled as follows: Treatment of infection-related fever in hospitalized patients. There are some situations where lowering temperatures is prudent, but to the title of the debate again, I hope I've convinced you and that you will vote in the favor of my argument that we currently overtreat infectious fever with antipyretics given the balance of adverse and beneficial effects of fevers. That's all.
Okay, awesome. So, Stephanie, you now have 5 minutes with a 1 minute warning, starting whenever you share your screen.
All right. I'll keep it pretty simple here and state my conclusion that we should be treating fever while we're treating the underlying process. You're not going to let your patients with pneumonia sit there just with acetaminophen in their system and not amoxicillin or fluoroquinolone. Treating fever is just one element of the many treatments that we give people with infection. And the whole point is to make the tachycardia, the hypotension, the aches, the sweating better, protect their brain. Again, think about before your shelf, if you've got a mild viral illness and a fever, based on that Sandfly study, are you really not going to give yourself Tylenol, knowing you could have a 20% decrease in performance? And acknowledge that infections are treated in so many other ways. We're not just relying on the body's physiology, right? We have great antibiotics. We have great supportive care, including ways to help patients eat and stay hydrated. And all of that is an important part of treatment while you can also treat the fever. And I would just stand by the tenet of, in a court of law, people or entities are innocent until proven guilty. And Zaven has showed us no study that shows a net harm treating fever. So I think treating fever remains an acceptable practice, one that's very patient-centered in quality of life, experience of illness, which as physicians is our job to alleviate. We're here to alleviate suffering, and fever is part of that. Thank you.
Okay, awesome. Well, thank you both so much. That concludes. Oh, there goes the lights. Okay, 1 second. Got to turn this back.
It's a very dramatic finish with the lights going out. It's like a mic drop, right?
Like on a timer and it just turns off on you. So, okay, so we're not going to move into 20 minutes of audience Q&A. Audience members are encouraged to vote on each other's questions to ensure that the most pressing questions are answered first. Questions should be directed to a specific speaker to answer first. Then, where appropriate, the other speaker may provide a brief response as well. Again, if this doesn't take the full 20 minutes, that's fine. We can stop early. So to give everybody some time to submit questions and vote on them, we've organized a few questions that we'd like to ask you both. Starting with Zaven, I'd like to ask you, have you stumbled upon any studies that have examined ways of like artificially raising body temperature, whether it's through like sauna or hot shower or like towel compresses to try to have some of those benefits of fever? Anything like that?
So the pyrotherapy studies, yes, right? So when people were trying to treat neurosyphilis before penicillin existed in the 1920s, that was exactly that. It was putting yourself literally in a hot box and for having no way to cool yourself, right? And like you're just eventually going to equilibrate. And that showed that that essentially, I wanted to just kind of explain the difference between fever, which is your hypothalamus deciding to elevate the set point of the body, and then your body doing things to elevate its body temperature, and hyperthermia. So medically, fever is essentially like an endogenous elevation in body temperature, and what you're asking about is hyperthermia, which is an exogenous sort of an elevation body temperature that is not what the hypothalamus wanted to do. And that can happen from overexposure, like heat stroke or something like that, right? Or overexertion, actually. When you're exercising, you're also generating heat, and then you sweat to try to dissipate that heat. But if you can't sweat enough, or you exercise sort of hard enough and for long enough, your body temperature can actually rise. And that's hyperthermia. And it seems like both the lizard experiments as well as the Nobel Prize winning discovery of pyrotherapy in its effectiveness of treating syphilis. And by the way, it's not just syphilis. The other infections too have been shown to sort of get better at higher temperatures, salmonella and others. there is evidence that exogenous heating, not just endogenous fever, can help to get over and survive infections.
Awesome. Anything to add to that, Stephanie?
No, I didn't know that.
Okay. One other question we have is the I guess mechanism of interferon. I guess that there's some studies that have come out that have shown that actually the raise in body temperature and fever leads to like an exponential increase at a certain point in interferon, which is highly effective in fighting off some of these pathogens. So any thoughts on that research, or have you seen that research?
I guess the question is interferon blockade, and I guess you're asking the effect on fever, or just want to make sure I understand the question.
I guess, yeah, my understanding is that some of the research has shown that like an increase in body temperature directly correlates with secretion of interferon.
That makes sense to me. I'll say I don't know the basic science well. But yeah, the fever, right? It's like almost the final common pathway of all these interleukins and interferons being made as part of immune activation. Actually, a slide I didn't show that I'll show you guys is the effect of a medication called anakinra, which is a interleukin-1 receptor blocker on temperature. And this was in the study of patients with super high fevers from a non-infectious rheumatologic condition called adult onset Still's disease. Still's disease is whenever you're evaluating someone with fever with just all these systemic kind of inflammatory signals, it's on the list for internal medicine doctors. So this is it's not an interferon blocker, but it's an interleukin-1 blocker. And it's just extremely dramatic, the effect that it has on temperature. And this is just, and this black arrow is when the patient in this study got the interleukin-1 receptor antagonist or blocker. You can see this is days. They were just super febrile, and then suddenly their fever is gone. So there's no doubt that sort of the mechanism of interferon and interleukins is there to drive fever. Prostaglandins have a big effect. That's one of the reasons why NSAIDs and others work. So blocking those hormones and signals absolutely has a big effect on fever, and that's something we think about when we're taking care of patients who have that immune suppression, whether from a rheumatologic condition or they have inflammatory bowel disease and there's on these unmet medications. It certainly puts them at risk for infection in the first place, but what their fever response is going to be if they've been recently administered one of those medications, I think is mitigated, and it makes it basically, as to Zaven's point, being on those types of medicines kind of reduce a variable that you have there to monitor a sense of whether an infection is present or how it's doing. Do you have anything you want to add to that, Zaven?
Yeah, I think that's sort of part of the kind of basic science in vitro, and I guess like the non-clinical outcomes that have been evaluated as affected by fever. That sort of slide that I presented on kind of there's a fever being toxic to the bacteria themselves. And by the way, part of that mechanism, I can go into later if people are curious, but the other way that it's thought to be beneficial in infections is that the elevated temperature itself influences and improves the function of the immune cells and what they're trying to do. So it's not just that there's immune activation that leads to T cell and macrophage activity and fever, both. It's that the fever, we have evidence that it subsequently enhances T cell activity, neutrophil mobility, and the communication between the two, which in part uses gamma interferon, right? I think if I remember my immunology, that's sort of the T cells. That's how the T cells tell the macrophages to go and eat the stuff that they need to eat. So yeah, the temperature being elevated itself causes increased secretion of some of those immune modulating, immune activating substances that then lead to the immune system doing its thing.
Awesome. Thank you. So we have quite a few questions in the chat. Yes, everybody please vote on these so we can answer the most pressing questions first. The one at the very top right now is for Zaven. The question says, what steps do you propose to quote unquote wean us off of the use of antipyretics?
What a great question. I think I sort of showed, or invoked the concept of an admission order set, right? So this is something that a lot of y'all will encounter soon, and many of you have who've kind of been through the clinics already. There's sort of a default set of things that we order for all patients who are hospitalized, or rather like that they're ordered commonly enough that in order to save time, they become part of an admission order set in Epic and CPRS, whatever. And essentially, it takes only, you're like admit patient, and this order set comes up, and it takes only one click to say regular diet, bed rest, or ambulate when possible, DVT prophylaxis or whatever. So a lot of these things just kind of an assumption, or like labs in the morning, right? These things that like, oh, most of your patients are going to need this, so let me make it easy for you to do it, right? And part of that admission order set, and part of why I think we overdo it and should do it less, is a one click, and it's a habit for most clinicians to one click order the sort of by default acetaminophen PRN fever. And that's the order. It's in the computer, and the nurses are going to carry it out, right? So I think one practical way to do that is to sort of remove that default practice from the order set, and thus not imply that it is medically appropriate to do. I think that's sort of a systems way to do it, but people will still go and seek it out and find it, even if you don't make it easy. Less so, but if they believe that that's beneficial, they're still going to do it. So I think we need just more education efforts, and this sort of want to congratulate you and your colleagues, Jeremy, for organizing this particular event and others like it. It's part of the education efforts that I think it will take in order to kind of move and trend in what I think is the right direction.
Yeah, thank you. Stephanie, anything to add to that?
I guess my only other comment is an argument against having that default in there for treating fever when it happens, where the nurses can just give the medicine. They don't need to ask permission to give the medicine. Is also like, you sometimes don't find out right away that they're having a fever. So I think just some of the sort of communication about what's happening in real time with the patient is another consideration. Now, again, you may decide you do want to give them acetaminophen, perhaps for the reasons that I mentioned, but sometimes those order sets, those default clicks that allow, permit the nurse to just give medication, no questions asked, make it harder for you to get to know the patient and what's happening on with them if you don't actually hear about it. So to me, that's like one more reason. While I generally don't click that box when I admit, mostly because I want the info. I want to know if there's a fever so I can think about why and what to do about it going forward, and then decide if I'm going to give them acetaminophen or ibuprofen or not.
Awesome. Okay, thank you both. So we have another question. How might you, this is for Zaven, how might you sell the idea of not treating a patient's fever to the patient or a parent, given Stephanie's point that treating fever helps the patient to feel better?
It's a good one.
Yeah. No, that's a hard sell. I think most things in medicine have complexity and nuance and upsides and downsides. And it takes time and care and understanding to not only know those that nuance and that balance, that potential sort of spectrum of what the right thing might be and what the downsides might be for yourself, and even more so to kind of explain that in an accessible way to a patient or a family member. So I think it wouldn't be easy. And I like Steph, don't I think there's definitely a gray zone, and again, I'm not saying that antipyretics are never a net benefit, only that we currently overuse them. But I think if a parent or a patient were again in the mindset of like my temperature is 101 and I need some Tylenol because oh my gosh, I have a fever. I need to lower that. I would just say simply, hey, I don't think it's a big deal if we get you some Tylenol. But I would actually recommend, or like, sorry, assuming that they feel fine, right? Totally asymptomatic, but just like they want to make the number better, right? I would just say, hey, there's some, the body gets a fever for a reason. It's trying to do something, it's trying to fight infection, and as long as you feel okay, there's some reason to think that the fever might actually be good for you. Now, if you again start feeling crummy, get a headache, you feel achy, let's get you some Tylenol. But as long as you feel okay, how do you feel about just kind of, letting it ride? Because again, it might be there for a reason. That's what I would say.
Anything to add there, Stephanie?
Yeah, I think it's just if you gain the patient's trust and spend time with them, that's just true of any intervention or discussion. But simply say like, this is a way for your body to fight this. If you feel okay, I think let's let your body do what it needs to. I think a lot of people would feel okay with that.
Sure. Awesome. So we'll move on to our next question. We have a question here for Zaven. Is there a fever cutoff that you think should absolutely indicate treatment? Stephanie, your answer here would be great too.
That's a good question. I'm just gonna throw one out, which is 104 degrees Fahrenheit. And I just totally randomly came up with that. But yeah, I don't know. I don't know if that's been studied. I certainly just don't know the answer to sort of, is there a threshold beyond which the physiologic liabilities are too much, right? And actually, if you go back to that trauma surgical ICU trial that I mentioned, right? It wasn't Tylenol versus never Tylenol. It was Tylenol at a cutoff of 38.5 Celsius versus Tylenol at a cutoff of 40 Celsius, right? So even the designers of that trial said, hey, if it's more than 40, which is about 104, we can't just like let that ride. So I think that would be my cutoff. Again, like symptoms are probably more important than the physiologic effects than the number. But that would probably be my threshold. Although I would really have to look at the literature maybe, and it depends on a population, like in kids, right? Like the risk of having febrile seizures. I've seen at least one study that shows lowering the temperature doesn't, or like giving Tylenol, trying to lower the temperature doesn't necessarily prevent febrile seizures. But I wonder what the subset or sub analysis of that data were in infants who have a temper of 38 versus 40, right? And I bet there's probably some signal that very extreme temperatures are probably worth lowering.
Yeah, medicine is so hard because you learn cutoffs and thresholds, and then in real life it plays out that everyone is different in their physiology and their comorbidities. And one of the studies that I looked at was just trying to get the answer of like what is normal in hospitalized patients. And at Cleveland Clinic, they did a big retrospective review of, they ended up looking at like 45,000 charts of inpatients and who they excluded people with infections. So people and other reasons for fever. And they said, just what is the temperature of people admitted to the hospital who shouldn't have a fever because of their underlying condition? It was a pretty big range. The 99% confidence interval fell between 95.8 and 99.9. It's a really big range. there was a 1 degree difference in most people from the low point of the day for temp, which is 4 to 7 a.m., compared to the high point of the day, which is 8 to 11 p.m. And age, as I mentioned, had a big factor. People who are older have lower temps. Body mass index, so lower body mass index, you've got a lower temperature. Women have slightly higher temperatures, very minimal. I mean, not significant in clinical practice than men, but there's just all these variables based on time of day, the age of the patient, their BMI, their sex, their underlying conditions. Where, as I mentioned kind of earlier in the debate, like an older patient who's got a 99.8 and isn't quite feeling well, just makes me start thinking again, not necessarily triggering treatment in everyone, but why is this happening? And really starting to think of that 99.8 as a fever that needs thinking about, both the cause of it and if we need to treat it or not. So it's so hard because it's easier to start with the absolutes, but in fact, I think the more you see patients and are a doctor, the more you start to move away from that. So I do not have a number at which I would treat. I agree. I think above 104, like I'd start feeling a little nervous, but if the patient were totally okay, I think Zaven makes a compelling argument for potentially withholding still.
Great. So next question, and just to confirm too, are you guys good still going to 8:30, or because we're already 17 minutes into Q&A, if we want to use the rest of the time? Okay, sure. So next question is for Stephanie. Is your pro-antipyretic viewpoint the same for a at-home over-the-counter treatment as it is in a hospital doctor-prescribed setting?
I think based on what I discussed, I would say yes, because the symptoms of how someone feels in terms of aches and pains and feeling hot and feverish, I mean, they're going to feel that way whether they're in the hospital or not. Now, someone's in the hospital probably because they're sick enough to be there, either because of the severity of the infection or their underlying risk factors from their age or their medical conditions. But the parameters of kind of making sure they feel better, I think generally would apply whether someone's at home or hospitalized on that principle.
Zaven, any thoughts?
No.
Nothing. Okay. Okay, so next question. This is for Stephanie as well. Some studies you brought up mention external cooling measures as opposed to pharmacological means of temperature reduction. Do you know of any data that explores the potential differences in outcomes between these two methods? If not, do you have any initial thoughts or postulates on what these differences might be?
I don't know of any head-to-head comparisons. Zaven, I don't know if you do, you can comment on if someone has a fever, right, putting cool packs on them versus Tylenol. But the cardiac arrest kind of treating fever and the benefits for that for neurologic recovery, those are all those studies are done with external cooling systems. Like the patient, it's called, they have brand names that are very striking, like Arctic Blast, like things like that. And the purpose of those external machines is because you can completely calibrate the temperature. You can keep someone at 98.6. Whereas when you give someone Tylenol, how much their fever goes down by may vary, how much an individual responds may vary. And so, in those post-cardiac arrest neurologic recovery studies, they didn't bother with ibuprofen and Tylenol because it just can't be as exact as a machine that, again, is just an external thermostat that keeps that person exactly at normal thermia. So I don't know of head-to-head comparisons, but the precision of control is stronger with external cooling. Again, I don't mean with ice packs and with ice in someone's mouth, with the actual bodysuit that's worn. And the way those work is cooled saline is pumped around the body. And patients' temperatures are monitored with invasive temperature management, usually either an esophageal or a rectal probe, and that allows very, very tight precision for those cases. But I don't think head-to-head been done, but my guess is that, yeah, it's just too unpredictable with the medications. Do you know more about that, Zaven?
Not necessarily, but I was just trying to think about how the whole thing works, right? So, um, endogenous fever, the kind of final common pathway is that, there's a lot of pyrogens that are released. So interferon and TNF alpha and interleukin 1 and interleukin 6 and probably others, they all get ramped up and they all ultimately lead to an increased level of certain prostaglandins that then alter the hypothalamic and increase the hypothalamic set point. And then the hypothalamus makes you, vasoconstrict and shiver and go find blankets and all the other stuff, right? And I don't know if the prostaglandins themselves, which is the step at which acetaminophen blocks the process, right? Acetaminophen doesn't reduce your production of TNF alpha directly. It just blocks the prostaglandins from affecting the hypothalamic set point, right? So acetaminophen itself isn't considered as a result immunosuppressive, right? So I think because if the point of intervention was lower, like more upstream of the immune process, right? Then I would say that acetaminophen, as opposed to external cooling, would have more deleterious effects on the immune response, right? That's what I would postulate. But I think it's pretty far downstream, such that if I were to guess, it's probably about the same. And regardless, though, external cooling, maybe that's not true. Just with ice packs and, kind of exposure and stuff like that. I guess you could do that just as much as you could give Tylenol if you thought there was a difference. But anyway, those are just some of my kind of like physiologic musings. But the short answer, like Steph, is that I'm not sure there's a difference. Probably I'm not.
Okay, so we're going to ask one final question. Before we do that, we're going to go ahead and release the exit poll to gauge if the audience has shifted at all. Maybe they have. So before that, we are going to also just plug our social medias here. Again, we're going to try to do this as often as possible, and would love to hear y'all's feedback. So, I guess we can't present that right now, but
I
that's okay.
have to ask, Ruby, when you have a fever, how do you feel?
Bad.
Yeah. How bad do you feel? Really bad or just a little bad? Okay, thank you.
That's all you need there for an argument. Yeah.
Yeah, unfortunately, it came after the poll, or is the poll still happening?
5, hopefully. Just kidding.
That's awesome. Oh, there's more. Okay, so our last question says, this isn't directed to either of you, so maybe y'all both can take a swing at this. For outpatient care, should we not be prioritizing the patient's immune response and overall recovery from illness over treating the inconvenient symptoms, which primarily serves to send patients back to school and work and us to ourselves when they are still sick?
I think yeah. I think most people with just colds and sort of run-of-the-mill common non-life-threatening infections, the major consequence of that is just quality of life and disruption of daily function. And yeah, I think I would slightly increased viral shedding, having the virus for 7 days but feeling okay with it is probably, I'd take that over having the virus for 5 days but feeling miserable the whole time. So yeah.
Okay. Stephanie, any final thoughts or anything the boys want to share?
I guess it's the same question. Hey, Simo, when you're Ruby, when you guys are sick and you have a fever, do you want us to give you medicine to help you feel better?
Yes. Yes, Lily just looked at my throat and it was so red.
That would be my sister who was babysitting them while we were on.
Well, we appreciate you both taking the time. That concludes our event this evening. Thank you both so much again for dedicating all the time into preparation and the discussion for tonight.